potentially extend the half-life of that medication. So you want to make sure that you're paying attention to that. When we talk about steroids, we don't want to use, for instance, a strong steroid in a place that's very thin, like an armpit. So we want to make sure, like, okay, in certain areas, we're going to pick certain strengths of medications or certain types of vehicles because that area is thicker or that area is thinner. Some of the general rules that we have and that you'll hear sometimes is if it's dry, wet it, and if it's wet, you want to dry it. And that's just a main idea of how we talk about if we want to moisten or dry a skin condition that a patient may have. So big thing here, same thing that we already talked about, reservoir, depending on where you're putting it, it can extend a half-life depending on what's going on, or potentially even shorten a half-life. And then you have different areas, paying attention to what's considered a thin area and a thick area, because this is what's going to come up. If it's dry, wet it. If it's wet, dry it. You're going to see that several times. So all of this other stuff, just don't need you to learn that. You're going to learn that stuff in derm. All right. The different impacts that we have to the efficacy of our topical medications. When you look at the regional variation in skin permeability, this is just saying that, hey, the thicker that an area is, that permeability is going to be inversely related to it. So if you think about like the heel of or the bottom of our feet in general, it's thicker. We walk on our feet, and so that stratum corneum there is thicker. So the medication, that permeability in that area is not going to be as great. So if I am very thick, my permeability is going to be less. And so if I am very thin, my permeability is going to be greater. So that's why the face, the scalp, all of these thinner areas that we talked about, that's why you have more penetration, because those areas are thinner. It is inversely related. When you talk about natural occlusion, this is going to be your growing area and under your arms, because we have hair. Well, some people have hair in those areas, right? So naturally, those things are occluded. And then if you think about it, we also wear, again, some people, underwear, right? And so we're covering that. So if I put a medication on my growing area and then I put on my underwear, now I am occluding that area. Same thing with babies with diapers, right? You put on a diaper after you put on medication, you're now occluding that area. It's equivalent to like if you were to put a Band-Aid on something. So make sure that you pay attention to that. When we talk about steroids, again, we're definitely going to talk about occlusion. The dose. So the more that you apply, the more likely you are to see some systemic effects. Some of the vehicles that we pick will also allow the medication to stay on the skin for a longer period of time, and therefore you can see more penetration that way as well, because that contact is lasting a little bit longer. Altered permeability of the skin. This is, again, those changes that we can have in the skin, whether they're positive or negative. You can sometimes see your medication absorption be increased or decreased. So depending on what's going on with your patient, you may have to change or alter that dose. Older people have thinner skin, so sometimes we'll have to decrease the dose that we're giving them, or sometimes, depending on what's going on. The more hydrated a person is, or the corneum is, the skin, right, the more permeable it is. So the more it can absorb. So just, again, looking at the bolded areas and understanding these are things that impact if my medication is going to work, because it is impacting whether or not it is absorbed. We're talking about our age. Kids aren't, just little humans. The dosing that we give them matters. So the surface area is a little bit different in how they systemically absorb things. So we'll pay attention to that. And again, it'll be pointed out a little bit more when we talk about our steroids. How often is someone dosing themselves? So how often are they giving it? Again, remembering that stratum corneum is going to be the reservoir. So I can say, hey, if my stratum corneum is damaged, now my reservoir isn't as good, right? So my half-life could be shortened in that sense. But if it's just the normal skin barrier that I'm talking about, you can potentially see a longer than normal half-life that we would see in a drug. These characteristics, this is just saying if something has a low molecular weight or if it's soluble, then it's more likely to be absorbed. That's our ideal drug. Do all of them fall under these principles? Absolutely not. Our occlusion, this is what we were talking about. So whether I apply it, a Band-Aid, plastic wrap, a cast, anything that occludes my skin from being able to breathe naturally, my hair, which is my natural occlusion, what I can see is that I can have increased systemic absorption in those cases. So occlusion equals increased systemic absorption. And then when you look at the vehicle or the delivery that we have, that vehicle is going to matter a lot. It's going to say, hey, depending on, like, let's say I use something that's an ointment. An ointment is very hydrating to the skin. So if I have an ointment that is hydrating, and like I just told you before, the more hydrated skin is, the more it's going to absorb. Therefore, you can see increased penetration, right? Because increased absorption, because it's going to get through that skin easier because it's not dry. That vehicle that you pick will also determine how that medication is going to be released. So when you hear things like ointments, creams, gels, it's not for nothing, I guess is the way to kind of say that. It is for a reason, because we're trying to control the rate at which that medication gets to the patient. This is going to be a big deal for the test and just understanding the different types of vehicles, because you can have the same exact drug. And let's say I had hydrocortisone. I can have a hydrocortisone ointment and I can have a hydrocortisone cream. I can have a hydrocortisone foam. Okay, so like understanding the different types of vehicles that are present is going to be the big idea with how you're going to get the correct medication and that correct dose to the patient. Okay, so when we think about an ointment, you can think about something that's like Vaseline thickness. Okay, semi-solid, it's going to be greasy. So when you think about putting it on skin, putting it on someone's face, ointment is not something that we would prefer in those areas. In certain situations, you will see that we do use an ointment, but for the most part, people don't want to walk around with a greasy face. So you do see that we have protection of the skin, again, in those areas that are going to be thicker. So like people, like their skin and their legs, people who have eczema, certain conditions like that, that is where we want to say, hey, can I get this medication, which is suspended in my vehicle, which is my ointment, to stay on the skin for a long enough time to penetrate it? All right. So these are all of the different types of indications that you can see it used in. When you see the lichenification, this is just where your skin becomes hard and bumpy in response to like repeated rubbing and scratching. So some people who just have a habit of rubbing and scratching in certain areas, or again, somebody who could potentially have like eczema, things like that, you can see where these conditions will happen to them, even that chronic inflammation. Looking at the patients who would benefit from this most, good for us to apply this in non-hairy areas. So thinking about someone who's very hairy, okay, you don't want to stick an ointment on them because it's just going to clump their hair together. And now, again, you've limited the amount of contact that that medication actually has with their skin. So we want this area to be as smooth as possible. Thicker areas are usually what benefit from this. Also, if we're using it in hairy areas, so even if we're talking about the scalp or like the growing area, sometimes with our ointments, you will see where they can develop folliculitis. That's just essentially that oil from the ointment building up into their follicles and causing them to have essentially bumps and irritation at the follicles. Looking at your gels, these are going to be things that are drying. They do have water and alcohol in them. So that's why you get that drying effect. These are very quick to dry on the skin. They appear clear, so you don't get that greasy effect like we talked about with the ointment. And you do see that these are the least occlusive. So when I think of a gel, I just kind of think of something that goes on clear and thin and does not cause a lot of, what do I want to say, an appearance to the skin that a person may not want, or like an adverse appearance. So good for acne, inflammation, because remember we said that if something was wet, that we want to dry it. And we said our gel has a drying drying effect. So that's why I also like it in acne, or if I have something that is oozing from someone having like dermatitis, where they came in contact with some type of irritant and their skin reacted and made like little pussy bumps come up on their skin. Also good in the scalp and hairy areas because it does dry fast, because it is the least occlusive. If I don't have a lot of occlusion, therefore I'm not going to have that folliculitis that I was worried about. These are just some examples. On the exam, I will tell you if something is a gel, ointment, or cream, what have you, so you don't need to remember that. I will tell you when you need to remember it, which will come up when we talk about our steroids. Looking at the creams, this one is essentially like a ideal type of situation, depending again on what you're trying to treat and where you are trying to treat someone. Okay. So when we're looking at this, you have your creams, intermediate drying. They're not as occlusive. They are very thin. They're not very greasy like our ointment, but they're like, as far as drying rate, kind of behind what you would think of with a gel. I'm not going to ask you about the composition of it. What I want you to know are these things that are going to affect a patient, right? So if they're a person who wears makeup, or if they're putting anything, sunscreen, what have you, on their face, medication goes first, and then they can apply whatever they want to after. You do get some drying effects with some of our creams as well. Looking at this, making sure that you're, again, paying attention to inflammation, and then in those thinner areas that we talked about before, right? So you're seeing this pop up again, good penetration, not occlusive. Again, I will tell you what falls under some of these examples. You don't need to remember the examples. A lotion. Think about lotion that you should put on every day. We are not having a lot of occlusion with lotion, right? And if you think about that, your legs, your arms could be hairy, and we can still put on lotion, preferred for hairy areas. Not very occlusive, so again, I don't get that folliculitis. And then when you're looking at the drying effect, this depends on the way that it is prepared. The more alcohol that there is in something, you can see more drying. When you're looking at this question, it says, if occluding an area, applying a topical med increases absorption, then why do occluded areas show decreased penetration? So your naturally occluded areas are showing decreased penetration sometimes. Penetration and absorption don't always go hand in hand, because I guess you could say it this way, if I can't penetrate, right, then I can't be absorbed. I have certain situations where when I have a natural occlusion versus me occluding, putting plastic, putting a Band-Aid, what have you, on it, the heat also from the occlusion can increase absorption into the skin. It can also make the skin wetter, which means now it's more hydrated, which now means that I am increasing the amount of penetration. So this is saying the same things that I've always told you guys. If you have an increase, a hairy area, that is also considered to be occlusion. So if I have a hairy area, I am now having decreased penetration. So if you just follow the principle of occlusion can increase absorption, natural occlusion can also decrease the penetration and decrease the absorption of a medication. So this is just, I don't know which particular area of the slide, and we can talk about it. But if you remember that principle, that's what you are likely to see it happen again or have a question about. Okay. So your lotions, if something is oozing, right? That's your exudative. If something is oozing, I want to, because I can have that drying effect, use lotion. With my aerosols, I think about this as how I think about like deodorant, right? Now we have spray deodorants. So it is your medication that's going to be dispersed in a gas, in gas, and it's going to be in a can. You don't have to have contact. So this is very good when you think about the hair or scalpy area, or if someone has like a fungal infection, or a large surface area, this is good for us because we can just have them spray instead of squeezing something out of a tube to put it on their body. So we do get a good benefit from the fact that we don't have that contact that's being required, which then usually spreads things. Again, scalp and hair areas is where it's preferred. Tinctures, these are kind of things that we used to use a lot back in the day, not so much anymore. More alcoholic solutions. They evaporate quickly because if you think about alcohol, alcohol can evaporate pretty quickly. Good for our scalp and our hairy areas, right? It's not going to clump anything together. You have your foams. So when we look at foams, again, pockets of gas, and then that's where you that are trapped in the liquid and your medication is dispersed throughout. So typically, again, we usually tell patients to shake this also. Higher cost because of the formulation being a foam. So the foams are going for your pockets. Good again in your scalp and hairy areas. And thinking about this, Rogaine is a great example that a lot of people use. Looking at your paste, powders, wet preparations. These are all things that aren't used as much, but they are important because we do have some situations, especially when we have like chronic skin diseases, where we will use things like this. So your paste, thick and dry, the more contact that it has with air, the harder that it gets. So I think about like toothpaste. Again, chronic inflammation, don't apply it to those weeping lesions or the hairy areas because, again, think about like toothpaste. If you leave toothpaste on your skin, it's going to dry out. And then if you don't have water and you had to like just rip it off, it would hurt. Okay. So, kind of that's how I remember, don't stop the weeping that's happening. Like, don't occlude it with my paste. And I don't want to put it on a hairy area. Your powders, think about like baby powder, things like that. These have that absorptive effect. So if I want something to be dry, I will try to use this. I can also use this to reduce friction. So if you have some people who come in and they're having chafing, right, their thighs, things are rubbing together, you can have them put it on their thighs. They caution with using it in like private areas. We know the lawsuits about like it could have potentially increased the risk of cancer. So good thing absorptive wise, putting it in boots, things like that, those thinner areas. If somebody has a parasitic or a fungal infection is where we typically will see that. So like athlete's foot, things like that. Your wet preparations. So when we look at this, this is just, again, trying to create a gradient between your skin and that dressing to try to leach the fluid away from that area of the skin to dry it out, essentially. So inflammation suppression, when we're cleaning out those wounds, trying to dry, again, something out. So we can use this on our oozing type of skin conditions that we may have. This is just some examples of what we do. We would put it on some type of gauze or something like that, and then have it ooze out onto the gauze, and then you remove it and kind of let that skin scab over. So when we talk about dermatitis, this is one of the big things that you're going to see in clinic that people are going to come and complain to you about. It could be due to an irritant or it could be due to an allergic response. When we talk about an irritant, this is something that they have come in contact with, whether it's bleach, whether it is a laundry detergent, what have you. Those are the questions that you start to ask sometimes whenever you see a rash. I have a friend, he was a painter, and he said that he went into someone's house and he didn't realize that the bleach had spilled on the person's counter. And he was leaning against the counter and the bleach ate through his skin on his arm. He's like, he felt something burning, but he didn't know what it was. And then his skin essentially started to slough off because he had that absolute irritant come in contact with his skin. So on first contact, whereas a relative irritant, this is something that over repeated uses to it, you can then start to see that breakout happen. Great example I had of this was I went to Vegas for my birthday, and usually I don't pack like my own soap. We were in an Airbnb, and I was like, I'll use their soap. It's like, oh, the soap smells so great. Day 2, maybe 3, we're out, and I started itching, and I mean head to toe itching, to the point to where I had to leave. And I'm going back in my head, and I'm like, what did I use? And the only thing that I could think of was that I used their soap. Had to go to a 24-hour CVS. Thankfully, I was in Vegas, right? They have lots of 24-hour stores, but that relative exposure is eventually what caused me to have the contact dermatitis, the relative exposure to that soap. You can also see this occurring with some different medications and different plants that people may have that they're allergic to. And then you just have that become irritation, an irritant to their skin. So these are your two. For your irritant, you have absolutely about to tear your skin up. Your relatives, they get on your nerves because they keep repeated, like over repeated exposure. You're like, okay, now you're getting on my nerves. Okay, relative. And then you're allergic, that is a hypersensitivity reaction. Okay. So, like when we think about something with poison ivy, things like that, and some people are immune to this because they got repeated exposure to it over time to where they're no longer allergic to it. But when you think about this as your body having an absolute like immune response due to some type of contact with some substance. This is an FYI slide. Not even going to talk to you guys about it. Just know there's different stages that can happen. And as the stages progress, the presentation becomes worse. So what you're going to do to treat it is you're going to prevent them from coming into contact with whatever they came into contact with. Hey, Raina, stop using the soap. Probably not a good idea for you. Okay. So prevention is the best thing that you can have because your patient is going to likely come in itching. They're going to have inflammation. They're going to, and the more that they itch and that inflammation occurs, they're going to scratch. Now, what happened to your barrier? You've broken your skin barrier, right? So the absorption of medications and the type of medication that you use then might be more harmful to your patient because now it's going to burn when I put it on because I scratched my barrier off. Okay. So looking at this, find whatever it is, remove it. Prevention is your best treatment that you have. We also have several different topical therapies that you can use, but it just depends on how your patient is presenting. Ointments will occlude your weeping lesion, which we want it to come out. We want it to scab over. Looking at those local anesthetics that somebody may have or an antihistamine, it may sensitize that patient, but it also might burn whenever they put it on. And then looking at your calamine, which is what a lot of people used to use back in the day, right? It helps, quote unquote, helps with the itching. And some people do still think that it does work, and sometimes it does, but it doesn't do a lot of good sometimes in some people, and it's very, very messy. So if somebody is presenting with mild contact dermatitis, again, I will tell you what they have. I'm not expecting for you to diagnose the patient on this. So somebody came and they had mild contact dermatitis. You have wet dressings, astringents, colloidal ointment, and low potency steroids that you can use. So again, with your wet dressings, your benefits are everything that's going to be in the bold. So pay attention to that. With your astringents, think of something that's kind of like your Domesboro, witch hazel type things. They're going to dry out or shrink those skin cells. What you can see sometimes, especially in people who have like lighter skin, less pigment, is that you'll see that blanching occur or whitening. This is transient and it will go away. That's due to the contraction of the tissue, which is going to decrease the amount of fluids that are coming to that area, which is going to decrease the amount of inflammation that is in that area. Looking at your aluminum acetate, you have your Domesboro as an example. And again, this is a wet dressing that we can put onto that patient to, again, cause that gradient to pull out that fluid. Your colloidal oatmeal bath, this is a good one for itching. And that's the main benefit that we get from this. It helps dry out those weeping lesions. Please make sure that your patient has a bathtub. If they don't have a bathtub, they can't use the oatmeal bath. Steroid, we're going to have a whole lecture over steroids, and you will learn which ones are low potency and high potency. So it's coming. Looking at your moderate contact dermatitis. When we talk about this, again, I will tell you if it's mild versus moderate. So we're looking at your moderate, what you're going to do is use a counter irritant. So again, something like camphor, menthol. You have your topical antihistamine like Benadryl. There's a topical spray or a cream that we have that's available. And then you have your moderate to high potency topical steroids that we have for your patients as well. So looking at your counter irritants, again, what that's trying to do is have your body essentially not respond to the irritant, which will likely decrease the itching and everything that your patient is experiencing. Okay, so you're banking on the fact that it is going to cause your person to be, your receptors to be essentially desensitized. Looking at your topical antihistamine, again, same type of thing, sensitization occurring. Sometimes this can worsen the condition. And if they are having a larger surface area that they're covering, or the integrity of their skin has been severely compromised, you can see that drowsiness, which we said happens with histamines because they're going to have more systemic absorption. And then looking at that moderate to high potency steroids, we'll talk about this, but it decreases inflammation because that's what we know our steroids do, but it also helps decrease some of the itching that those patients may have. Becomes very important because it depends on where that dermatitis is. Again, if I'm talking about the face, there are certain steroids that we will only use on the face, and we'll get a little bit more into that later. Looking at your severe contact dermatitis, so this is typically them not responding to a lot of these other medications, so I will tell you that. You will then give them systemic steroids. So if they are severe, they get systemic treatment. That means my topical preparations, which is all of these other things that we have talked about for your mild to moderate, all options that you had were topical. In this situation, they would get systemic steroids. We usually use prednisone. Okay, I don't need you to remember the dosing schedule, but prednisone is the go-to that we like there. Your seborrheic dermatitis here, you don't need to know anything about the presentation. I'm going to tell you what they have. What I need you to know is the treatment. So an antifungal shampoo, which is ketoconazole, and we also have a low potency topical steroid. If that is not in a scalpy area, there are some options that we have that we could use, but the potency kind of increases a little bit. But we'll talk about that when we get into that steroid lecture. So you'll have things like hydrocortisone 0.5 to 2.5% that you can use, triamcinolone, desinide. Those are some of your low potency topical steroids that you could potentially use for this type of dermatitis that you have. With the ketoconazole, what's important about this is that it is a shampoo. You can also use it on their body. So it's not like it's restricted to just their hair, okay? They put it on, they don't rinse it off for about 5 minutes, and then they rinse it off. So that can be a little uncomfortable, right? Because you're in the shower for 5 minutes and you're like, okay, water can't touch whatever this area is. So just make sure that your patient knows they're not just washing themselves and washing it off. They're washing themselves and leaving it on so that the medication can work. Looking at your atopic dermatitis or your eczema, again, don't need you to remember all of this. This is just a part of our triad that we talked about. I want you to pay attention to the treatment. So eliminate whatever that allergen is if you can figure out what the allergen is. Increase skin hydration. The way that we do that is by a lot of the ointments. So when you have a chance to pick a steroid, most of the time we will try to pick it in the formulation of an ointment. We try to use the vehicle, the ointment vehicle, because they are going to have those thicker areas of skin because eczema is very itchy. Okay, so they're going to be scratching their skin a lot, and their skin becomes thicker over time. And so ointments are what we typically prefer for their medication vehicle, but we also prefer that for them to put on their skin. So you see we have just regular Vaseline or petroleum jelly and Eucerin. We do have a form of this behind the counter. Your patients will love you because it will save them about upwards of $15, $20, depending on what size of Eucerin they get. Please be aware of your patient's body size. Don't give them one little tube and say that it's going to last for 3 months or one little tub. They're probably going to need more of that. The bigger or the thicker they are, the more they're going to need. Okay. So don't be stingy. We have it for them. Make sure you're ordering the right amount. We also have Cetaphil behind the counter for them to be able to use to wash their face. So a soap-free cleanser. That way it's not drying out their skin, because remember, with this condition, their skin's already dry. They don't need you to help them. They need us to hydrate them. So again, this could save them quite a bit of money because they can go over the counter and buy this, but we also have this out. Your weeping lesions that you have, again, you see your Domboro and your colloidal oatmeal. This was, again, those preparations that would cause the skin to essentially dry up. Your corticosteroids, you have medium to high potency that you're going to look at. And then looking at your topical immunomodulators, or your TIMs, not Tim's the singer, that's my girl, but TIMs, like topical immunomodulators. You have your pimecrolimus cream and your tacrolimus ointment. And then you have systemic therapy. This is depending on your patient, depending on also what they have to do. Some of your patients will tell you they are extremely itchy. And even when they've done all of these things, they are still itchy. Sometimes you can still give them an oral antihistamine. They're not controls, right? They're just going to have the potential of causing that drowsiness. Both of these are very popular options that you have, your hydroxyzine or your diphenhydramine, which is your Benadryl. So it's something that you can prescribe to them just in case they're having a flare where it doesn't work. Looking at your TIMs, I just want to get through this section and then we'll take a break. Your calcineurin inhibitors is another name for TIMs, but your mechanism of action, what you're doing is your calcineurin binds to T cells and it causes that immune response. And so our system essentially gets activated. So, our immune system is cutthroat, right? It's trying to get to whatever the problem is and get rid of it. If I can try to inhibit the calcineurin, right, this medication is trying to block that downstream effect of all of those inflammatory mediators, which causes that inflammatory response. So your calcineurin inhibitors or your topical immunomodulators will bind to that FK protein to stop that immune response. That is essentially your mechanism of action. The words that are underlined, if you have a mechanism that you see in the bolded, that's what you're going to see if you have this for a mechanism of action. Here are your two products, which are what we already talked about. Okay, mouse, let's go. Looking at your clinical use, we already said our atopic dermatitis, chronic inflammatory skin diseases, psoriasis, eczema, things like that are what we're talking about here. These are great alternatives if you don't want to use a steroid, because our steroids can have some nasty effects. What we see here is that this has a better side effect profile, especially if someone has a chronic condition. If you have a chronic condition, that means that you're going to have to use a medication, likely chronically. So if I can spare them the long-term effects of their steroids, next lecture, if I can spare them those steroids, then I am having a good benefit in my patient, right? So that's where you see this better side effect profile and why we call it the first line steroid sparing agent. Okay. Looking at your efficacy, if you're comparing your tacrolimus to your pimecrolimus, your tacrolimus, or when you're comparing either of these to a steroid, your tacrolimus is equivalent to a medium potency steroid, whereas your pimecrolimus is equivalent to a low potency steroid. So again, when we talk about the areas in which we're going to use it, right? If I'm telling you genital area, I might want to stay away from the tacrolimus. Pimecrolimus is a better because it's almost like a low potency. So you see where the vehicle comes into play as well sometimes, but also the area in which I am treating will dictate the potency of the medication that I want to choose. That thinner area can't take it. The thinner area doesn't have thick skin, literally. Okay, so I want to be nicer. I want to be, let me give a lower potency. Maybe you can handle this. Okay. Adverse effects, burning, warmth of the skin. Huge amount of your patients will experience this. It can go away over time, but it is something that is very uncomfortable at first. Potential of having some skin infections and flu-like symptoms happening. So the headache, fever, chills kind of things are your flu-like symptoms. Again, a pretty big number. Looking at your caution, make sure that they're using sunscreen. They're not just going out to tan. Okay, UV exposure can increase their cancer risk. And then it does have a black box warning for, you guessed it, cancer. Okay, so I don't want to further worsen that in those patients. So rare cases of lymphoma and skin cancer. So what we want to do with that is decrease how long we're using this as well. You will see some of our steroids, depending on the potency, we can use them for about 6 weeks as well. Again, varies on potency. But you want to stay around that 6 week mark with this, or use intermittent treatment. So you'll say like, okay, we're going to do a week on, a week off, a week on, a week off, a week on, a week off, or you can alternate even with a steroid sometimes. All right, let's take our 10 minutes and come back on their face. They don't like it. So derm is a big thing that y'all will likely see. When we're looking at impetigo, again, I'm going to tell y'all what's going on, but this is a infection that's essentially caused by our gram-positive bugs. Most of the time, staph. You'll see where when we're trying to put steroids and things like that on there, it might not work. Okay. Most of the time, well, it's not going to work. I'll tell you that way. It's not going to help. So what they need is they're going to need to have an antibiotic, because I just told you that it's caused by a bug, and my bugs, right? My bacterial infections need an antibiotic. And so when I look at that, you're wanting to see here your topical steroids, no place. But what I do have is my Bactroban. We learned about this, right? Mupirocin, 2%. This is my drug of choice that I have. You're going to use it for 5 days. And then our mechanism of action, or revisit inhibiting that protein synthesis of the bacteria, and therefore it dies. Okay. So thinking about this, staph is what's causing it. So all you need to remember, impetigo, I need mupirocin, 2%, Bactroban. Okay. Antibiotic because it's caused by a bug. Looking at why all of the things happen, FYI, right? Sometimes it could be a follicle plug, sometimes it can be bacteria, sometimes it could be an inflammatory reaction. We have to figure out what it is. Sometimes it could be hormones. So we have to figure out what it is. You're going to see P. acnes come back up again. So just understand, if it is bacteria, the typical bacteria that's usually causing your acne is going to be your P. acnes, which is a gram-positive anaerobe. And that will come into play when we start talking about our mechanism of action of some of our drugs. So when you come in, we want our face to be fixed fast. Okay, fix my face now. But that is not how this works. It takes time. So 1 to 2 months is needed before you can even look at their treatment and say, this is a failure. So at most, 2 months. People are very impatient. I am one of those people. When something is going on with my face, I'm like, I need something. Give the medication enough time to work, you're not going to see those results. So it's very important to you to set expectations up front with your patients so that they know what to expect. So at least 2 months before you're like, okay, let me try to give you something else. All right. So if you're looking at normalizing follicular keratinization, hyperkeratinization is essentially what's happening when the cells of the follicles aren't shedding correctly, and then it can cause a comedone for that patient to appear. So you have benzoyl peroxide, retinoids, and azelaic acid. If their issue is because they're making too much sebum or too much oil, like oily skin, you have retinoids and you can manipulate their hormones. So hormone treatment. Suppressing bacteria, if they have a bacterial etiology, then that's when you're looking at that P. acnes. So we have different medication for that. So then you see your antibiotics, right? We talked about benzoyl peroxide, retinoids, azelaic acid. You see no steroids here because there's bacteria. And then if it is an inflammatory response, again, depending on what it is responding to that inflammation for, you can see antibiotics and retinoids if that is the cause. You want to get the underlying issue. The reason why you don't see any steroids typically used in acne is because we have to figure out what the underlying issue is. You can continue to put a low potency steroid on my face for a very long period of time, but if you don't know what the cause is for me, then you're exposing me to a steroid for a long period of time, which is what we are trying to stay away from. We keep saying that, don't give steroids for a long time. So again, when you're talking about acne, this is a slow repair of the skin, and it takes time for those medications to work. A very popular medication that the patients can get is going to be benzoyl peroxide. This is the most effective one that we have. This is one that you can prescribe often. You also see this available to patients over the counter, so like Clearasil. And there's several different generic versions that are available as well. So how do these work? They release oxygen. Remember we talked about that P. acnes, it doesn't like oxygen, anaerobic. So when I say, haha, I have oxygen, now I'm killing that bacteria. Therefore, I'm helping that patient with their acne. What you also see is it has that dual action, right? It's an irritant. So it can increase the sloughing of the skin or the turnover of those epithelial cells and helps promote the resolution of that acne that they have. Also, someone has dark spots. Because I'm turning over those skin cells, I can now decrease the appearance of their dark spots that they have. Good against inflammatory and non-inflammatory acne, most effective. I already told you that. You do see that it's going to take some time, right? So when they're looking at this is even hitting almost over or I told you 1 to 2 months, and you see this is on the lower end. It can take longer. Some patients don't like the side effects that we're going to talk about, and they may not even make it that far. So just make sure that you understand that it is slow, but you have to set expectations. You can see here where when we add it with other things, so depending on why they have their acne, but if we add it to something like erythromycin, antibiotic again, y'all can't escape them. If we add it to erythromycin, you can see where the efficacy of my benzoyl peroxide can be enhanced and vice versa. So when we have that combo product, now I'm having better chances because I'm attacking the cause like in 2 ways. I'm attacking that bacteria in 2 different ways. Looking at my adverse effects, photosensitivity is going to be something that you're going to see with a lot of these medications, but you also see a burning and stinging sensation. This is what is uncomfortable for your patient. Over time, this will subside and it will get better. Their skin will say, oh, I'm used to this. So if they're putting on this medication, they need to put this on first, and then they need to put on their sunscreen, right? Because I told you photosensitivity, which means sunscreen, and it's drying. So they also need to moisturize. A lot of sunscreens are moisturizing. You don't want people to put too many things on their face because then they're clogging up those pores that you're trying to help them clean out. Okay, so make sure that they just get like a moisturizing type of sunscreen, and that should help them with the photosensitivity as well as the drying of the skin. People will pill from this medication. Remember, it's an irritant. So that's why we see that drying effect. It's irritating and drying. Your applications start low and go slow is essentially what this is saying, because you don't know how sensitive someone's skin is, right? My old face has been through lots of things, so I can put more things on there. I'm more tolerable to, I can tolerate them a lot better. Whereas someone who is younger, someone who doesn't ever put anything on their face, right? They don't manipulate their skin, they don't go get chemical pills or any of that stuff. They are going to need a lower concentration because it's going to be more irritating to them. Their skin is like, wait a minute, what are you doing? So start low, lowest concentration before you start increasing to get better results. And you may not even need to increase that dose for them. Discoloration. So we do tell people to use this at night because of that photosensitivity, right? The downside to this is if someone has dark colored sheets, dark clothing, or anything that is in contact with the area of the skin that they're putting this medication on, it will discolor it. So please make sure that they know that. Get a light colored sheets at that time, or a light colored pillowcase at that time while they're using this medication, because it will bleach darker fabrics because it has peroxide in it. I don't know who's older, or I don't know if people still do it, but we used to try to bleach our hair with peroxide, right? So you can lift color out of things. That's the same type of idea here. So remember, your benzoyl peroxide is irritating to the skin. The peroxide, oxygen, right? Your mechanism of action, it's killing that bacteria that is on the skin, and it can bleach or discolor my fabrics, drying things out. So my topical antibiotics that I have my clindamycin, my erythromycin, and then you see what we talked about on the previous slide with our benzoyl peroxide. I can add those in, and I have my combination products. Okay. Mechanism of action, suppressing the P. acnes, and then again, that subsides, or that causes you to have that decreased inflammation and decreased appearance of their pimples or their comedones that they have. When we look at our clindamycin and erythromycin, I don't know if anybody remember what types of inhibitors those were, 50S inhibitors, but that combo is more effective, right? So again, we want to try to increase the efficacy if we can for our patients. So a lot of the times we do start, and patients might go on their own and get that benzoyl peroxide, and if it's not working, then of course the combo product is better. Also, the benefit of that combo product is that we're decreasing the possibility of resistance because I'm also using the benzoyl peroxide for its effects as well. Looking at your clinical use, severe acne, off-label for rosacea, which we'll talk about a little bit. Already said this. Looking at your adverse effects, again, because I have that benzoyl peroxide, I see that irritation and the burning, but because I have my good old Clinda, we said Clinda gives me C. diff, right? So the longer after that 2 months, which is where we see if our medication is actually working, the longer that you expose them to this, the more likely they are to see that occur, the C. diff occur. Just because something is an adverse effect does not mean that it happens. It means that it is a possibility, okay? So if, of course, someone experiences C. diff, I'm sorry, your face can't be cute because you're on the toilet, okay? So we're gonna take off that clindamycin for them, stop that benzocaine if that's the one that they're using, okay? And then looking at this, next slide, our systemic antibiotics. So minocycline, doxycycline, tetracyclines, right? When we look at this, these are used last line, your topicals have failed. Nothing else is working. Your patient has waited up to that 2 months. They have no resolve. This is what you're looking at. This is the most effective thing that we have, but we don't want to use this first because now we're systemically exposing them to our playbook. We're giving them those antibiotics on a daily basis. You see here that it's not going to affect any existing comedones or pimples that they have. It's just going to prevent them from having new ones. So that's something that they would have to go get extracted if they want those out now. But what you should see is that over time, they will stop having those lesions or those pimples coming up on their face. This is, again, after we've tried everything else, daily for over 4 to 6 months, and then we taper them off of them once their acne has improved. A lot of people, their acne will come back, and then you start using this again. You do see it take a while for it to work, so they need to be patient and understand that they're taking something every day for possibly up to 6 months. Looking at your retinoids, we love the retinoids, okay? These are vitamin A analogs. They can decrease the sebum production that the P. acnes need to essentially survive, right? So my bacteria, they like to bathe in oil. I just think about like germs just in a nasty, oily area, and then I get this nasty pimple on my face, okay? So what you see here is that if I'm decreasing the amount of sebum, my P. acnes does not enjoy being here. Not a fun place to be. So therefore, I have less comedones present. You also see that I decrease the inflammation by decreasing the chemotaxis that is occurring in that area. Remember that these were our workhorses. These were very, very effective when we talked about our acne vulgaris. These were the ones that we were also talking about we could potentially use. So we save these if we can save these. So that's why you see you're using it after you've tried the benzoyl peroxide and potentially a combo product before you get here. So it's between essentially this and you using antibiotics. First line in your inflammatory and non-inflammatory acne, if for whatever reason your patients can't use one of your topicals that are available. Adverse effects, drying, peeling of your skin, redness. If somebody already has dark spots, it could potentially darken those dark spots. You see this more in darker pigmented patients. Banks, don't look around at anybody. And then you also see your photosensitivity. So a lot of these meds, photosensitivity. Looking at that pustular flare, this is something that is very important to tell your patients because they will be mad at you. I came to you to help me with my pimples, and I've been on this medication, and now my face looks a mess. it will clear out all of the old things, those lesions that were forming under their skin or about to come out. All of those then become visible to your patient. Okay. But after that first couple of weeks, it does go away. We talked about whenever you see photosensitivity, always think about sunscreen. Again, that's because of the degradation of the retinoid that occurs whenever it comes in contact with UV. So again, this is another one that we try to apply at night, just like we try to apply that benzoyl peroxide at night. Um, with this one, not recommended in pregnancy. So you have your tretinoin and your adapalene. These are category C. They shouldn't be, you let them have their baby. They let them know their skin is going to be all over the place. And most of the time in pregnancy, your skin is breaking out because of hormones, not necessarily bacteria. And then you have your tazarotene and your isotretinoin. These are both category X medication. So at all costs, you're avoiding these because we have seen very detrimental things happening to the fetus whenever they deliver them. And again, we already talked about that, applying it at night or once they're in for the day, they're not going back outside or the sun is down. You have your tretinoin, which is retin-A, adapalene, which is your differin, and your tazarotene, which is your Tazorac, which is the one that we typically use, or you have Avage. These two you've heard a lot about probably, especially if you watch commercials. You see that we have several different formulations. Don't need you to remember the formulation. See that we can also use these with our benzoyl peroxide for our inflammatory acne. Your adapalene, equally effective. One isn't better. One isn't better than the other, but you do see that this one is better tolerated. This is more irritating to people. They say that the stinging and the burning feels a lot worse with retin-A than your different. So that's why you see the better tolerated and the faster improvement. And then your tazarotene, and also both of these, you could potentially get these, your patient could get these over the counter depending on what strength they're getting. Your tazarotene, cream and gel, this one has the best efficacy, only behind the counter. You see that the gel is more irritating than the tretinoin, which we said. So this is number 1, irritating, number 2, irritating, number 3, irritating. Indicated more so for your patients who have psoriasis. Looking at your isotretinoin or your Accutane, this one is an oral retinoid, right? So all the other ones that we were talking about were topical. This one is going to be your moderate to severe acne. You can also see that you can use it in some rosacea off label. Looking at the adverse effects, it's a lot of them, right? So you have cheilitis or chapped lips. Just think of your skin just being completely dry, okay? People will get nosebleeds because their skin and the mucosa is so dry. Their eyes, they're needing eye drops to like lubricate their skin. I mean, everything is just dry, okay? It is sucking everything out. Agranulocytosis and elevated LFTs. These are 2 big things that you definitely need to make sure that you're monitoring. Again, those dark spots can get darkened, photosensitivity, hair loss can potentially happen, and fragility. So again, whenever you're thinking of this, a lot of things are, I think of it as like just sucking the life out of something. Like everything is just dry. Your nails are dry, your hair is dry, your skin is dry, your lips are dry. Okay, that is your isotretinoin. You see, it's drying up your mind too. Depression, psychosis, suicidal ideation. That is the way that I remember the isotretinoin. But when I tell you that it is a great medication, okay? It is very effective and it works. But you see that this is teratogenic. So much so that we have the REMS program. We have what's called I Pledge, isotretinoin, I Pledge. The provider, the patient, and the pharmacy has to register to make sure that we're saying, hey, you cannot become pregnant while you are on this medication. So when a woman is taking this medication, she needs to make sure that she has 2 negative pregnancy tests in the clinic 30 days apart before even starting the medication, and monthly while taking the medication. What this looks like, before we used to let people take a pregnancy test at home. Problem with that, it might not be accurate, or they might tell you that they took a pregnancy test and they didn't. and they're actually pregnant, and now we've exposed them to a teratogenic medication, which is not what we're aiming to do. So 2 pregnancy tests in a clinic, at least 30 days apart. Most of the time, a provider will do that second one right before they prescribe that medication, okay? And what the woman is pledging and what the provider and the pharmacy is pledging is that we have all overstated that 2 forms of contraceptives need to be used while they are taking that medication, and at least 1 month after they have stopped the medication, because the medication needs to get out of their system. So 1 primary form of contraceptive and 1 secondary form of contraceptive. So a primary form could be that I am using birth control. Okay. I have an implant or an IUD. Those are the things that is considered a primary form. Your secondary form would be, okay, I know that I'm taking this, or I know I have this implant, or I know all these things, and I know that they're not 100%. So I also need to use a condom, a cap, a sponge, whatever. It has to get past 2 goalies, okay? So they need 2 forms of contraceptive. They can also have 2 primary forms of contraceptives, but nobody should really be doing that. You shouldn't have an IUD and a combined oral contraceptive, because that's too much estrogen, progestins, all the hormones that we talked about. But what you can potentially see as well is someone saying that they're abstinent. So that is also a primary form. But you still need to make sure that you're telling them, hey, you still need to make sure if you do choose to have sex that you are using 2 forms of contraceptive. Okay. Monitoring, make sure that you're monitoring those LFTs, because I just told you that they can have those elevated liver enzymes, their lipids, CBC, right? A granulocytosis, and pregnancy. I want to make sure that they are not pregnant. So when we talk about abstinence, you need to make sure that you're telling them what abstinence means. It means no sexual contact with the opposite sex for 24 hours a day, 7 days a week. None, 0. Okay. Acne rosacea. So when we look at our rosacea, this one, again, I'll tell you what it is, so I don't need you to worry about any of this on this side, except for your patients who are going to come in. They're going to tell you, oh, I drink coffee and I get red. That is a trigger. Spicy food, trigger. Liquor, trigger. Alcohol, like all of the things, right? The heat, the sunlight, all of those things can make a normal person turn red. So with a person who has rosacea, they are more sensitive. So make sure that you, again, if you can, remove the trigger. And then avoiding certain skincare products like astringents or things that have alcohols in them. Oils, some people like to use oils that can, again, be irritating to the skin. Just make sure that they're avoiding those things. Looking at your treatment that you have, we have several different options that are available. So you see, I can try to stop any papules, pustules, any redness that they may be experiencing, any burning, things like that. In your patients who have mild to moderate rosacea, they're just going to be using this alone, or you can use it in combo in your severe patients with an antibiotic. Okay. So again, combo treatment for those patients. You see all of your topical agents here that I'm pointing to that you can use. So you have your topical metronidazole. Remember, those antibiotics are never going anywhere. You cannot escape them. Okay. Your azelaic acid or your phenacia, your sodium sulfacetamide, and your bromidine, okay, or your Muvaso. Some of these will require prior authorizations. It depends on what is going on with our formulary, and it changes, okay? You can look this up as a provider by going to the TRICARE formulary lookup tool before you prescribe a medication. You don't want to irritate your patient, okay, and make them mad when they come and we say, oh, Muvaso right now needs a prior auth. You are the one who has to do the prior auth. The PA has to do the PA, okay? Or if they need a medical necessity form, you still have to do that. So you can easily check that. And I suggest that on any of our medications that we have for derm, because a lot of these come on and off of the formulary quite a bit. So looking at your metronidazole, very popular one to use, drug of choice if they have those papulopustular rosacea. Your azelaic acid if it's mild to moderate. Your sodium sulfacetamide with sulfur in it, it does kind of have a smell to it. You see, again, we can use this in acne and our dermatitis that we have, but I also can potentially use it in rosacea. And your Muvasa or your brimonidine, you can use this if it is persistent redness that they're having from the rosacea. But again, because that's something that's almost what they consider cosmetic, you may or may not have that being covered by TRICARE at the time. Azelaic acid is another one that goes on and off of the formulary, but mechanism unknown, possibly the antimicrobial and anti-keratinizing effects are why we see a potential with this when we're talking about our rosacea. So using it in rosacea, we also saw this when we looked at our acne. Looking at this, it doesn't have a lot of toxicity. Those adverse effects look great. Again, that burning and that stinging that we've seen in almost most of our medications are still here over time, does tend to fade away. And then hypopigmentation in patients who have darker skin complexions. So now the melanin can be depleted, hypopigmentation. So instead of those dark spots getting darker, they will lighten it, but it's going to lighten several spots on their face. So if they're not applying this to their entire face, you could be creating splotches essentially over someone's face. So just make sure that they are aware of that and that you are aware of that for your patient. Formulations, Azelaic, which is 20%, and your Finacea, which is 15%. Your 20% of your Azelaic, acne, A&A. Your Finacea is for your rosacea, okay? Azelaic, acne, Finacea, rosacea, okay? Two different things that we have here, those as far as those brand names go. The strength is different, indication is different. That is a fair one to ask you because we are talking about both of these things with acne, okay? Again, currently, I believe that we have a prior authorization that is required for the Azelaic, but the rosacea, so your Finacea, is on the formulary, and this is safe in patients who are pregnant. Okay, this one is a category B, I believe. Looking at your Mavaso, remember this one is the one that we said was Lafline, alpha-2 adrenergic agonist, selective, and then you see that we decrease that redness because we have vasoconstriction. So again, this one, last time I checked, had a prior auth and a medical necessity form that you would have had to fill out. Last line for that persistent redness that they are experiencing. Adverse effects, because of the vasoconstriction, they may temporarily have flushing that occurs. That's where they essentially lose the coloring of their skin, depending on how big their face is. But I'm just joking. They can also see where their blood pressure drops. This is not something that should be that dramatic or something that is harmful to the patient unless they typically ride low. You can see where that would become a problem. All right, psoriasis. This is something that can be very difficult for a patient to deal with. They have papules and plaques that are all over their skin. It is a chronic disorder. There is no cure for it. It is an autoimmune disease that they think may be related to like genetics and environmental triggers. Nothing that I need for you to remember from this slide. Now, what I do need you to look at is your mild to moderate versus your moderate to severe. The treatment will vary depending on what is going on with your patient. I will tell you if it's mild, moderate, or severe. So this is the classification is depending on how much of their skin is affected. So less than 5%, we can start with topical therapies, and we can potentially do and combine that with UVB phototherapy. My moderate to severe patients, they have a greater extent of body involvement. 5 to 10%, you see that you have the topical agents, but it's not an option now to do the UV. What the UVB is doing is it is slowing down the rate of that skin cell production. So that's why we're trying to combine it with the treatment, because remember, they have these plaques that are forming, these thick plaques over their skin. So if we can combine this with the phototherapy, this helps our patient. And then if that doesn't work, the topical with the UVB, you can see where we also add on the systemic treatment. The greater the amount of body surface area that is involved, the more likely you are to have them on some type of systemic treatment, right? I might then have to switch you to oral treatment because I can't have you lathering yourself and me dispensing like 50 bottles of a medication to that patient if it's very, very extensive. So if we go back to the previous slide, this person needs something that's more systemic versus this person. I can look at topical because it's just in blotches. This is all over his body. His essentially his whole body is covered. Okay. So think about how that would be for you to try to apply something topically to your skin. It's a little more difficult. Okay. So just keep that in mind as you're doing some of these things. When you look at your mild to moderate, and even when you're looking at your moderate to severe, if you can, your topicals are better than your orals because you don't have a lot of those side effects, right? Because I'm not having as much systemic exposure. So choose your therapy based on the individual, how they're presenting, all of the different things that you're going to have to take into effect when you're looking at which medication you're going to use to treat your patient. So you have all of your topical agents listed under the topical agent heading, your UVB phototherapy, optional if they are mild or milder patient, looking at your oral agents that you have, and then your biologics that are available to you. Okay, and we're going to go through these medications. What do I want to tell you about this? Remember, your topicals are where you're going to go first unless somebody is more severe. So looking at my topical corticosteroids, first line thing that I have for my mild to moderate, looking at this, I can combine or alternate this with my vitamin D analogs, tazarotene, or some type of emollient, like something to moisturize their skin very well to improve the efficacy and decreasing how many adverse effects they have, because steroids are going to come with adverse effects. So I try to use my vitamin D analogs or something else that has a better side effect profile if I can, so that I can decrease the adverse effects that my patient could experience from long-term exposure to a steroid. Because again, just like when we talked about that eczema, this is something that is a chronic condition, right, with no cure. Looking at my concerns that I have, efficacy or how good my medication is working is going to increase with the potency of my steroid. The side effects are going to increase also with the potency of my steroid and how long I use it. Looking at the lower potency agents, those are what we prefer in those thinner areas, right? My growing area, my face, underneath my armpit. And then again, limiting my high potency agents to 2 to 4 weeks. Now, for exam purposes, we are going to talk about steroids in depth. There's a whole lecture that y'all have on steroids. If you want to get a jump on that for tomorrow, you can look at the different potencies and remembering where they fall based off of the percentage and sometimes even based off of the vehicle. But you will be required to know for the exam, oh, this one is a very high potency. Oh, this one is a low potency. Okay. Those can be just straight up questions that I ask you. So even when you're looking at this has to translate to, oh, if somebody has mild to moderate psoriasis, I can give them a topical steroid. Okay, which steroid? Oh, well, where is it? If I told you that they only have it on their face, oh, I need to pick something that's low potency. Okay, which ones are my low potency steroids? Okay, so being able to sort through that is also important. Looking at your coal tar. This is mild to moderate psoriasis. Again, not as effective as my topical steroids, but this is a cheaper option if someone does not have insurance, but it is also a messier option. You can see the photosensitivity, skin irritation happening. And because of how messy it is, and this is almost exactly what it kind of looks like on people's skin. But depending on how, because of how messy it is, you can see where it stains light colored fabrics and also just any clothes. It's just very thick. It's not fantastic. Carcinogenic in animals, we haven't seen this in humans. And like I told you, I just think about coal tar. It smells. Think about tar, it smells. Looking at your vitamin 3 analogs, what you have here, calcitriol is going to be your active form of your vitamin D. So what this is doing is this is regulating calcium to promote growth and remodeling of bone, essentially. Okay, so of healthy bone, trying to get that to happen. When we talk about the role in psoriasis, we don't know exactly how it's working, but what we think is happening is that it is slowing down how fast the skin is growing, and therefore that decreases the plaques for those patients. When we look at our options that we have, you have calcitriol, calcipotriol, and calcipotriene, and then calcipotriene with betamethasone and dipropionate, which is one of your steroids that we're going to talk about. So when we look at this, the one that you typically see used the most is going to be your calcitriol, because it has less irritation than our other options that we're talking about. Looking at our clinical use, we already beat this one, right? Mild to moderate. And then once you get to moderate to severe, you're more likely to have to use combination product. On an exam, I will be very clear as to what that patient has. Is it mild? Is it severe? What's going on? Looking at your combo products, I told you with that betamethasone, you see that it can be combined with a corticosteroid, and therefore my efficacy should be improved. If somebody is needing to use something for a longer period of time, I can use this for maintenance, but it does have a slower onset than whenever I'm talking about my steroids. But hopefully with this one, we do see that we have sustained remission, meaning they won't have another flare up again. We shouldn't be using this with any of our acids, or it could potentially deactivate the vitamin D3 analog medication that we're trying to give our patient, okay? Looking at your calcitriol and your calcipotriene, equal in efficacy, but again, I told you that your calcitriol was the one that we use most because we don't have as many of those adverse effects or that skin irritation that's happening, right? Which we said happens with a lot of our topicals. So skin irritation, itching is one of the big things that we're looking at. Make sure that if somebody has low levels of calcium, that we are monitoring their calcium levels. And then looking at your calcipotriene, your calcipotriene and your betamethasone. When you're using these two together, your betamethasone or your steroid can cause that HPA axis suppression. So that's why we're watching out for that, not for use on your face, flexures, genital areas. We'll talk about that. That's because of that betamethasone portion of it. Looking at your tazarotene or your Tazarac, right? We saw this already. This is now just talking about it in the mouth, plaque psoriasis context, and then understanding that you can also add this one with a topical corticosteroid. Teratogenicity that we talked about can't be used on those sensitive areas, those skin areas. So again, you can still see lingering effects of this medication, which is why it's a great medication after they've stopped it. So up to 12 weeks, you can still see where this medication is still working. Acitretin or Soriatine, this one is another medication that is an oral. So how we kind of talked about our isotretinoin, this one is your acitretin. Oral, decreasing that inflammation by, again, stopping the chemotaxis that's occurring. Monotherapy or used alone in regards to talking about psoriasis, that UVB is a plus or minus if the patient wants to use it or not, and if you think that it would be beneficial or not. Derm can also weigh in on this very heavily. You can see that we can also use it with biologics, steroids, calcipotriene. There's so many different options that we have. So usually once we get to this is more for your patients who are like, hey, they're not responding to just one thing. That's usually when you'll see that adjunct. And so that's because they're refractory or, again, very, very severe. You don't have as much organ toxicity as when we talk about the methotrexate and cyclosporin that we're going to look at in a moment. Again, like with your isotretinoin, you have a lot of dryness, the alopecia, the triglycerides, hepatotoxicity, right? Those LFTs is what we're looking at with the hepatotoxicity. This side effect profile looks very familiar to what we talked about whenever we looked at our isotretinoin. Now, the teratogenicity. When we talk about the teratogenicity, you have to make sure that you're understanding how serious it is. This one is contraindicated up to 3 years after they discontinue their medication. Okay, so your isotretinoin, we said that one was, they had to wait at least a month. Like, we needed to make sure they were still using 2 forms of contraceptives at least a month after they stopped it. This one is 3 years. The program that they have is called Do Your Part. Pregnancy prevention actively required during and after treatment is what Do Your Part stands for. That's their program. So pregnancy prevention actively required during and after treatment. So do your part is good enough for you to remember for the exam. Also, if someone is younger, the upper, I hate this word, y'all. You know what it is saying, right? Epiphysis. I don't like this word, but this will close, which means that you can essentially stunt their growth. Okay. Looking at your calcineurin or your TIMS, these are back again, same medications, same mechanism of action. We talked about using this with our patients who had eczema. Again, clinical use, same thing, steroid sparing, right? Alternative to those topical steroids. Side effects, black box warning, all of those things are still there. New drug, cyclosporin. This one, the brands matter. So when you see something that says bioequivalent, what that means is that you could then use them interchangeably. There's a book that is out there that tells you if drugs are bioequivalent or not. Sometimes even the pharmacy will go back, will look at somebody's profile when they're on certain medications to make sure that you didn't change the brand of the medication that they are on, because it does affect the response from the patient. So you have Sandimune and Neoril, which are not interchangeable. Sandimune is an IR capsule, and your Neoril, this one comes in a micro emulsion, and it decreases sometimes the absorption that could happen depending on the person. So a lot of the times you don't see Neoril used as much as the Sandimune. It just depends on the patient and what works for them. Clinical use, severe, refractory, extensive, types of issues with the patient, making sure that you're understanding that this is not a first line thing that you're going to go to, but it is an alternative to somebody who wants something that's cheaper than a biologic, or somebody who has a severe disease in one of those areas that's very hard to penetrate, like the soles of their feet, the palms, what have you. And then again, I told you severe, you see that involvement of their body is at least over that 10%. So that's where we were trying to shy away from topicals as much, because it's a huge area of their body that will require you to prescribe a lot of topical medication. You can use this in combination with other medications. And then again, the use is limited due to the adverse effects, the interactions, and the fact that it's not bioequivalent. So sometimes whenever there's a back order, meaning that medication, like the pharmacy can't get that medication, you will see where the patient kind of gets stuck, because I can't just switch Sandimune for Neoril. So that's why you also sometimes don't see us using this as much. Nephrotoxicity, again, different cancers happening from the medications, the triglycerides are out of whack, more monitoring for you to do, right? So monitoring their renal function, monitoring their triglycerides, making sure that they're not pregnant, because it is a category C, okay? So a lot of these drugs, remember, I'm the pharmacist that doesn't like meds a lot, right? You put them on something, don't leave them on something. Figure out how you can take them off if you can. A lot of these chronic skin conditions, we can't do anything about it, and our patients do end up on them for a pretty long period of time. Aprilimas or Otezla, this one has a lot of commercials. PDE4 inhibitor, not PDE5, like our Viagra and things that we talked about. The way that this is working is decreasing those inflammatory mediators, right? So therefore I have decreased immune response that's happening. This one did require a prior authorization. So in the system, again, before you prescribe it, always you can just easily go into the TRICARE formulary, look up to Google that, and see if the medication is going to be covered. And that if it requires the prior auth from you or not. Your moderate to severe psoriasis, who are the people who you're going to treat with this, not as good as your cyclosporin, but what we have is that we don't have all those side effects. We don't have as much monitoring as what we needed before. You do see that I am using this in patients who want an oral treatment or require an oral treatment because it's so extensive. But I don't want to keep coming in for you to monitor my LFTs. I don't want you to keep making me come in for all of these things. So this is a good option for that. Adverse effects, GI issues, which could then lead to weight loss, depression, suicidal ideation. So at baseline, if they have this, please make sure that you're watching out for that. Upper respiratory infections, do not use this in pregnancy, and not good for our patients who might have the presence of a CYP inducer on board. And I will tell you that the drug is a CYP inducer if I give this to you. Methotrexate, I'm going to finish this portion and then we're good. Methotrexate, folic acid antagonist that's going to inhibit the purine synthesis because it's going to act on that dihydrofolate dehydrogenase. And so what we essentially need this for is for us to replicate DNA, RNA, our protein synthesis. And you also see where it inhibits cytokine production and then can lead to immunosuppressive effects and those anti-inflammatory effects. That's the overall what we get. Now, these immunosuppressive effects which is why you're going to see this used in several other conditions. You'll see this in several different patients. You guys will talk about this more later. In this context, just make sure that you're looking at it from the derm portion. That's what I'm going to talk to you about. So severe, refractory, extensive, last line, right, type of issue that we're going to talk about. This is a pill. I want to make sure that I'm stressing that this isn't something that they're topically putting on. This is a systemic treatment for the patient. Not as effective as our biologics, but they're a lot cheaper than our biologics. Think about biologics as being newer drugs that cost more money. Anything that's new costs me a little bit more money. And then I realized that we have, okay. Adverse effects, ulceration can happen and inflammation. So that stomatitis, GI issues and GI irritation. So what we do is we supplement with folic acid. This is a very, very big deal. Most of the time when we're giving methotrexate, they don't take it every single day. And sometimes on the days that they're not taking it, we have them supplement with folic acid. This is a big medication error drug. We see a lot of med errors because of methotrexate and people not taking it properly. We talked about this side effect profile being pretty nasty. Myelosuppression, pulmonary toxicity, hepatotoxicity. So what does that mean for you? You have to monitor all of these things. Monitor their pulmonary function, monitor their liver, get your CBCs done. This requires a lot of work from you because of those adverse effects that can happen. Because of all these adverse effects, don't give it to me because if I'm pregnant, right? Teratogenic. Very important. So methotrexate has an X, category X, teratogenic. Don't give it to them. Make sure that they, even after they stop taking this medication, that they don't try to get pregnant at least one menstrual cycle after. And for males, this is one that's accounting for those males. You see the 3 months again because of the life of the sperm. We do have a reversal agent. I told you that this is one of those big ones that we see with our med errors. We can use leucovorin, which is a folinic acid, and that supplies that cofactor, again, that is blocked by the methotrexate, which is the same reason why we supplement with that folic acid. So your leucovorin is your rescue if somebody has too much methotrexate that they've been given, okay? Leucovorin is your rescue. And then the last one that we're going to talk about today, your biologic agents. Understand your mechanism, stopping the inflammation, those cytokines, stopping that, which then causes the cascade again, activating those T cells, the whole inflammatory response. We don't want that to happen. Most effective thing that we have for our psoriasis, you have your adalimumab, your infliximab, your etanercept, and your ustekinumab, okay? Humira, Remicade, Enbrel, and Stelara. We'll get more into these when we talk about arthritis as well. You see that these are injections that people are given. Your infliximab is IV, and it is the most effective one that we have. They do come into clinic to receive this treatment. Moderate to severe psoriasis, I can add with my acitretin or my methotrexate if I needed to supplement. This is going to be more so for your severe patients. And then looking at your risk of infections, we'll talk about this again, but you can have reactivation of latent TB if somebody has that. So risk of infections are very, very important. Make sure that somebody doesn't have lupus or any other types of cancer or TB prior to initiating it, and not as toxic as our methotrexate, acitretin, and our cyclosporin that we talked about, but they're hitting the pockets. It costs more money because they're newer. Unclear because they are newer on the pregnancy status, but we don't typically use our biologics in our pregnancy patients. So tomorrow, what I'm going to try to do is I'm going to try to finish this in pregnancy to where we can cancel class on Thursday. So tomorrow, be prepared to finish this. We're going to look at corticosteroid lecture and the pregnancy steroid or the pregnancy lecture. So I'm going to go pretty fast tomorrow so that we can avoid Thursday if we can. I'll see everybody tomorrow. I'll stay on a little bit for questions.